First of all, again, this is a mover recognition and the panel that we're going to have in just a few minutes. We established our mover recognition program in this spring, and a mover is a meaningful use vanguard, someone who has attested or their organization has attested to meaningful use, and someone who has really championed the effort. And I'm going to just keep going. My changer isn't up here. So I'm just going to kind of read a little bit to you and tell you a little bit about the MOVER program. It was originally established by the ONC, and it is through the ONC and the Regional Extension Program that this is being carried out as a way to recognize and honor the people and the leaders that have come together to drive this important transformation of healthcare. The program recognizes those who are really championing the effort in their organization. We're going to put up a slide on the next one that kind of shows the objectives of the MOVER program. CMS and the Regional Extension Centers are on the base of the program, offering funding and technical support on EHR adoption. The MOVERs are in the middle layer, leading the adoption in their organizations, and ultimately the patients benefit from improved outcomes. Many of those that we are going to recognize today are also early adopters of the Health Information Exchange, so we congratulate these individuals on being leaders in their organization. Many individuals, as I mentioned, we started this program in the spring, were presented their MOVER Awards in the spring, and we are going to recognize not only those individuals, but some new movers that we're adding to our program. At this time, regardless of when you received your recognition, whether it was in the spring or right now, we'd ask you to just step forward so you can be recognized. Our movers. And not everybody is here, so we'll just kind of go through these rather quickly. And Kara, if you can advance the slides. We have Dr. Awan from Regional Family Residency Program in Rapid City. Brad Bertrand from All Points in Elk Point. Heather Bindle from Rapid City Medical Center in Rapid City. Dr. Bosworth from Independent Medicine in T. Dr. Braithwaite from Sanford in Sioux Falls. Angela Chambers from Horizon Healthcare in Mission. Dr. Scott Acarius from Acarius Eye Clinic in Rapid City. Melissa Gilbert from Orthopedic Surgery Specialists in Aberdeen. And Dr. Jeff Johnson from Lewis and Clark Family Medicine in Yankton. And I know you're here, so you have to come forward. Dr. Kim Junt from Avira Aberdeen Family Physicians. Dr. Kidman from Destiny Family Medicine in Sioux Falls. Dr. Jennifer Kruger from Regional Medical Clinic in Rapid City. Brian McAlpine from North Central Heart in Sioux Falls. Sheila Orr, also from North Central Heart. Daryl Riddle from Rapid City Medical Center, and I know you're here too. Haley Shep from Sanford, Sioux Falls. Dr. Simmons from Regional Medical Clinic in Rapid City. Dr. Smith from Regional Family Residency Clinic in Rapid City. Aaron Stark from Fulton Area Medical Clinic. Kathy Boltz from North Central Heart. Scott Weatherall from Horizon Healthcare, and he's on his way up too. And Dr. Rita Settle from Sanford's Women Health Plaza in Sioux Falls. Please, let's just give a round of applause to these folks. Thank you. We will be adding an online form in the spirit of being paper-free, but for right now we just have some paper nomination forms in the back of the room just for your convenience today. If you are interested in nominating someone from your organization to be a mover, again, the criteria are that the person must, or the organization must have attested to meaningful use. The individual also must be recognized as a champion of this effort in his or her organization, and helping healthcare providers and others realize the challenge, and not unsurmountable challenge, but just helping people through this transition. Can be a clinician, an administrator, or a member of the office staff. And again, the forms are at the HealthPOINT booth. We will have these on our website, so you can fill an online form out to nominate an individual. And if you have any questions about the program, or again would like to nominate somebody and have a question, please feel free to ask me or a member of the HealthPOINT staff. Thank you. Now we have a panel discussion, and I'm going to invite our panelists to please come up, and I'm going to ask Holly. She's going to be our moderator for this discussion. We have some tags up here if you folks want to come forward.
Well, while the panelists are getting seated, I am not standing up at the podium this time. I'm just going to walk amongst you. And I'm not sure if everyone knew, but there were some green cards in the back of the HealthPOINT booth that we asked if you had a question that you would put the question on the green card. I have no green cards, so everyone needs to think of a question at this point that you would like to ask our Meaningful Use Vanguard panel. And I think probably some of the great questions are those hard and poignant questions about how do you really operationalize meaningful use? What does it really look like? Those types of things. So let me introduce these fine people who we're going to put these questions to. And they have the answers already, so don't worry, you're not going to trip them up, right? First, ladies first, Ms. Haley Shep. She's the Director of Meaningful Use at Sanford. And she has quite a physician list to get through to get them attested. So she's doing a great job, and like I said, has quite a number of physicians to coordinate those meaningful use reports. Next, we have Mr. Darryl Riddle, and he is the CEO for the Rapid City Medical Center. Again, a large facility, getting larger by the day, I think, over there. Next is Chris Sonnenschein, and Chris, your title up there, but I have it here. And Chris is the Executive Director of IT Clinical Support at Avera in Sioux Falls. Again, large facility that has a lot of cats to wrangle, right? And then we have Dr. Brian Johnson from Lewis and Clark Family Medicine, and representing, right there. Yeah. I'm sorry, I should have looked at that, right? Dr. Jeff Johnson. I think I was, sorry about that. Dr. Jeff Johnson. Yeah, I'm going to pay for that one, aren't I? When I come visit your organization, I will pay for that one. And he represents a small provider office. You have two other providers in your office, and he is the lead physician in that office. And so he'll give some perspective in that one provider office. So, are we ready? Okay. You don't have mics. Is everyone comfortable with projecting? And
I can have a mic.
Oh, okay. We can pass? Pass. Well, I'm going to start with Haley. I have a question. Haley, tell us what really have you heard from the providers maybe a case study or just one particular benefit that you've seen that meaningful use has brought to patient care? And everyone's going to have to answer this question.
Sure. I think there's lots of them. I'll keep it simple. With stage 1, I think even just the e-prescribing objective really increased patient safety, reduced medication errors. I also think that computerized provider order entry is another one where we're increasing patient safety. That being said, I think that a lot of those more evidence-based outcomes are yet to come. Kind of think of stage 1 as, okay, we're getting things ready. We need to put all the workflows in place, get our EHR functioning the way it needs to be, putting things where they need to be so they can be extracted. I think that come stage 2, even stage 3, we'll see more of those evidence-based outcomes.
Excellent. Thank you, Haley.
Hi. We have seen some pretty nice improvements in patient care, in particular specific chronic disease management. The diabetes is the one that really jumped out at us because we always had trouble coordinating For instance, the eye exam, and was it done, and did the primary care doc know that it was done? And we even have ophthalmology and optometry as part of our practice, and we still couldn't keep it straight on a paper chart. So we found that managing chronic care, no surprise, was so much more complete when we did that as a part of the EHR.
Thank you, Donald. Chris?
Yeah, I've got a couple of things. Something for meaningful use, just as simple as this. We noticed in a lot of our EDs are capturing height and weight for young kids. So, meaningful use kind of forces us to do that. Not real shiny, but a couple other things. Interestingly, I think this is patient care as well. Drug seekers. We've had a patient at one of our clinics looking for some pain medications for something he was denied. Then he went down 50 miles and went to another Avera doc, and right there in that same medical record says it just the day before he was looking. So those type of things. Other clinical decision support, I know we've uncovered, and this was when we were migrating, just starting to roll out the EMR and starting to take some advantage of clinical decision support, duplicate tests. And I think it was when we found a patient had more CTs than he or she needed, and the EMR was able to present us with that. Medication reconciliation, closing the loop, that's a big one for me. It kind of ties into the e-prescribing and on an integrated medical record, both hospital and clinic. As we e-prescribe and do medication reconciliation in the clinic, as a patient's admitted to the hospital, providers have the ability to do this continue from ambulatory, so you can grab their home medication, and because of the mapping that we've done, intuitively converts it to an inpatient med, and then on discharge, then an ambulatory script on the way out. So it really kind of closed that whole medication loop. And as everybody knows in this room, med rec is almost like chasing a pot at the end of the rainbow. You know it's important, you just never get there. We're close.
Great, thanks. Dr. Jeff Johnson?
Well, yeah, first of all, asking to serve on a specialty panel and talk is a little like asking Larry the Cable Guy to come and lead worship at your church. So we'll see if we can get her done.
So you're the comic relief then on this end. Okay.
Yeah. So, yeah, there's your son. Me getting involved in meaningful use happened because HealthPOINT, Tara back there, walked through my door one day and said, hey, you're small, you're not too bright, you probably need us to come and help you, which was indeed the truth. And so they came on board and they let me. So how it has impacted our practice is, but med reconciliation is one of the doctor's biggest problems. And when you see, like we said over there, 15 different doctors in a day, or the average Medicare patient has 15 different doctors they see, and has 15 different medications, and managing all that. So that has improved. Also tracking of lab is also another one that has improved, and tracking their procedural things that have been done. Getting those copies from them, that they had something done at Yankee Medical Clinic, or they had a procedure done at Avera Sacred Heart Hospital. We download this into our EHR, and that also becomes part of our record, so we can track to see what's been done and what's not, but the duplication of services is down, and overall patient safety is improved.
Excellent. All right, I'm going to ask one more question, and then the expectation is that the audience will participate. Okay. Now, we've seen that very minimally, stage 1 had required some patient engagement, very minimally, and really just introducing them to possibly a laptop or a tablet within the point of care visit. How are you planning to get to the stage 2 requirements of patient engagement? And we'll start here with Dr. Johnson.
What are the stage 2?
He's going to have Tara come in, is what's going to happen.
I would need some guidance on that.
The patient portal that you download and transmit, really you being responsible for, tracking whether your patients are actually looking at their health information.
We're actually in the process of switching our EHRs to a different vendor. and they have part of their, one of their bells and whistles that have been remarkably improved. We don't have a patient portal currently. And that'll be the addition that they're going to bring to our clinic is a patient portal. So how that's going to work, I don't know. I'm a little fearful because when patients ask for copies of their labs and they see an abnormal lab that to me means nothing, but to them freaks them out and scares them, then they have questions. That the patient portal is going to trigger a lot of patient questions about what things mean. And then, am I going to put down an obesity diagnosis in the patient portal?
Not on my record, please.
Exactly. There's going to be some offenses
Can't handle
there. Yeah. So there's some tricky things that are going to handle with that. But I think it'll be a fun. I think fun. I think be a different word, but it'll be. I think it'll be a useful process and engaging the patient in their care probably a little bit better.
Great, Chris.
We're in a similar boat. We're ready for stage 2, 2014, both the federal fiscal year and the calendar year for the EPs. We're embarking on that. We just finished an upgrade to our stage 2 certified platform. So we have not rolled out the portal yet, but we're in the project planning phases right now. But I can kind of share with what we're talking about. You know, initially when those thresholds came out, and wait a minute, you're going to hold me accountable to make the patient go to the portal? Why should I be accountable? This is all pass, all fail. All of our money's hanging on actually patients going to the portal. How are we going to do that? Once I kind of got over that, I started thinking about this. And what are we trying to accomplish? Well, it's everything that we talked about this morning too, patient engagement, patient empowerment. We can only deliver so much. We need the patients. We got to stop trying to heal the sick and help manage chronic conditions, help people take ownership in their care. So we absolutely need them at the table. And who better to get them to the table than their healthcare provider? So once we got over that, we started thinking about how we're going to do it. And we want to try to make it easy for patients. So some of the things that we're kind of throwing around in the hospital at discharge, might we have iPads at the nurses' station? So kind of as part of your discharge instructions and everything else you go through, you actually sit with the patient and help them enroll on the portal online and kind of show some of the bells and whistles features of it. And that doesn't check the box as far as that's concerned. But then by enrolling, we've shown them they've been able to log in, and when they get home, they're going to have an email welcome to the portal that then they'll be able to access from home if we educate them correctly, in hopes that they do that they communicate with us in the portal. Clinic, something very similar, but clinics, you have patients moving in and out every 15 minutes. Is that the front desk staff? Well, they're busy checking patients in, paying bills, scheduling. Does the nurse have time to do one more vital, if you will? Those are the things that we're working on out, but we're going to try to get them while they're in the clinic in the hospital, just to get them, their engagement, their interest, and get them enrolled in hopes that we'll play with them when they get home.
Excellent. I have a personal story to add to what you just said. It worked. Absolutely. What you did worked with the nurses, showing someone how to do that. My daughter, I have a grandson. I know I'm way too young for any of that, so we won't even talk about that. But she lives in Salt Lake City, and they have the same system that you guys do. Not Epic, sorry. And over in that organization where she had the baby, and they have a patient portal. She never signed up for it when she had the baby, and she was in there. She came to visit me for 3 weeks, and she went to an Avera clinic. And the time that nurse took to show her how to get onto the portal, she actually signed up and is now using the portal. So it works to have that nurse take the time because they trust that nurse. They trust that provider to say, you know what, this is how it works. Explain it to them. So kudos. Good job. Daryl.
When we first started using our EHR, of course, there was an opportunity to begin to collect email addresses, and that's how we communicate with the patients, of course, when they signed up for the portal. We didn't really push that very much with the patients. We had a lot of pushback from them that they didn't want to give us their email. They were afraid we were going to start sending marketing information to them or God knows what. We've slowly worked our way through that. But even once the patient signed up, they would get an automatic email from the portal saying, thank you for signing up, here's your temporary username and password. And we were finding that patients first of all, didn't open it because they couldn't figure out who it was from. They thought it was junk mail, so we had to find a way to make sure the patients opened it to look at it, and then to help them find a password that they would actually be able to remember. Because the password that came from the portal was just a bunch of letters and numbers all jumbled up and meant nothing. And so we really tried to talk with them about, okay, be sure and get a new password, one that you could remember, because there's some good stuff on here. We also have been pushing just the whole idea of, hey, this portal's out there, trying to get more patients interested. And recently we've kind of been talking about how can we put a little more pressure on the patients to want to use the portal, because again, we're the ones that are being judged here in terms of how effective we can be with that, but the patient is at least a 50% player in that equation. So we've kind of been talking about maybe going to the health plans, especially the local health plans for our local employers, and going to them and saying, would you mind reaffirming with your beneficiaries in your health plan that it's important that they get engaged with their provider and encourage them to take advantage of portals and secure email through the portal, et cetera. So we're still working on it. We're not anywhere close to where we need to be, but we have some ideas.
Wonderful. Now, let's expound just to touch on that idea with the health plan. Are those formal agreements that you're creating, or just cooperative, like friendly agreements with them then?
Basically, what I think what we would do is, again, this is kind of a brand new thought I just had in the last couple of days, but we would ask them just to provide some education to their beneficiaries about the importance of having access to their medical data. Because one of the things that Ms. Archibroda talked about this morning, and I asked her, well, what about the patients? You know, we're just not seeing where the patients are being held accountable for much. We're being held for the patient's performance, et cetera. And so my thought was, if we can get the employer or the health plan to start pushing gently on the patient to understand why it's important, then we've just got another angle to maybe be successful.
Thank you.
You know, the patient portal piece of meaningful use stage 2 is by far going to be the arch nemesis to achieving stage 2. You know, I think everyone in the nation recognizes that this is probably the biggest hurdle of stage 2. Obviously, because it's a patient-driven objective, and it requires a culture change. So you really need to demonstrate the value of that patient portal or that electronic access to the patient in order for them to get using it. Not only is it a culture change for the patients, but it is for providers, nursing staff, registrars. Another way to do that, I think, is to really look internally first. You know, take a look within your own organization or clinic and say, let's start with family first. Who signed up here for electronic access? You know, once you start using it, you begin to see that value and can better speak to it. I eat, live, breathe meaningful use every day. And when my daughter got pink eye, I literally picked up the phone and I called and left a message with the nurse. Now, why I did that? It's solely because we're creatures of habit. But, you know, had I thought through that, and I did send a message after. But I went and sent a secure message to the provider and got a timely response. But it's really just kind of rewiring our brains, you know, into using that. In addition to changing the culture, I think there's a lot of marketing ways. You know, if you can kind of demonstrate that value, use your marketing department to help with that. Health plan is a great idea. Even education for your employees.
That was going to be part of my question for you, was who's on that group that is talking about patient engagement? And anyone can answer that, or just that you're planning for that. Who are you including in that?
Everyone. Lots of providers, nursing staff, registration. I mean, it takes a village to make this movement happen. Like I said, it's a culture change. As far as the marketing team, I think you can look at the inside of your own clinic and say, okay, how can we best change this? You know, what information can we provide them? It's also all in the presentation. You know, if my husband were to walk into the clinic and you said, would you like to sign up for, all he heard was, do you want? And he said, no. So you kind of have to look at ways to approach it differently. As a mother of 2 young children, I'd like to know that I have access to immunization records for school and whatnot. So you kind of have to look at it from different perspectives. Geriatric patients, how do you target that population? A number of them or some of them aren't going to have access to internet or smartphone or computer. But what about proxy access? So you kind of have to get creative and figure that out.
So really developing a communication plan about who those people are and what messages they would need to hear. And that really is, your marketing people would probably need to be involved in that.
Yep.
So great, okay. Now, thank you, Amber. Where's Amber? Amber, guess what, Amber? Because you're the first person, and you're awesome, you get a prize for asking a question. So Jan's right behind you with some books from Carolyn Hartley in the AMA, and you can pick one of those. So thank you, Carolyn. Amber's question is, what are some of the tips or advice to engage providers about details of meaningful use when they're busy taking care of patients? Dr. Johnson, you want to start with this one, or?
Alcohol.
Now that's HealthPOINT's trick, mister.
Saying. Engaging providers is difficult. We just had a staff meeting at Vera Sacred Heart. Physicians, the med exec physician representative stood before us and told us, I think he was referring to ICD-10 and how we're going to have to give our discharge summaries and the way you have to word your discharge summaries in a certain way. And you could just see eyes start to roll and blank faces. But provider engagement is difficult. And the specific question is how to get them to invest in
details, engage them about details of meaningful use. When they're busy, they're taking care of patients.
You guys got some ideas?
You can pass the mic.
I would say just be persistent. Keep it in front of them, let them know it's not going to go away, that they might as well listen because you're going to be back another day to tell them again and again and again. And we use chocolate, not alcohol.
Same receptors. It works on the same receptors, just so you know.
Yeah, I agree. We use food. Lunch hour meaningful use education seminars have been very helpful. I've actually had a number of meetings recently where I've had really engaged providers. Everyone's talking about stage 2 meaningful use, and if I can get in front of them and at least talk about what the regulations are, it usually opens a line of communication, which in turn is usually opening a can of worms and talking about challenges and barriers. And I tell them, this is exactly what I'm here to do today. I want to hear about these potential challenges so that we can work through them. I think once they kind of hear the regulation, they can kind of give us kind of their feedback and how it impacts them and what we can do to help them so that we can best serve the patient.
How do you make those convenient for the providers?
I go once and twice and 3 times, and eventually I hit them all.
Yeah, and it's
that's
probably some individual stuff and maybe
individual lunch hours.
outside regular hour type of stuff.
Anytime I can catch them, even if it's a conference that we've got for our APPs or one for physicians or unit meetings that they're at anyways, and I can kind of sneak in, monthly or something.
We started an internal marketing campaign early on, especially where meaningful use really started to get providers, CPOE, prescribing, physician documentation, those types of things. And had a marketing campaign internally for a good year through planning so that everybody knew it was coming. But then you also, as an organization, when it came about, we really needed to ask ourselves at the top level, are we in or are we out for meaningful use? We all have to sing the same tune. And operations, IT, and quality all said, yes, this is a priority for us. So that we cut the ambiguity out of it so that we kind of moved down the path. And then, as we're moving down some of these implementations, CPOE, one of the challenges we get, if you're going to push us into cookbook medicine, and I like my order set, we engage physicians in the process, whereby we have some evidence-based authoring tools. We brought physicians in by specialties for 1-day sessions, 2-day sessions. They made investment production credit, I'm not exactly sure. We put the power back in their hands to sit down and help author order sets and documentation templates that's going to fit their workflow. So that they had some skin in the game and they had some ownership in the answer.
Dr. Johnson?
No, that's okay. I think you
And I think for stage 2, we have a real opportunity with clinical decision support with that requirement. You know, that really should be a physician-led type of program. So if you haven't started thinking about that, it would be a great way to get your providers engaged because they know what they'd like to see in terms of alerts. And it gives them some ownership too, I think, of that. So I think the point of finding out what they value within the clinical documentation and then trying to get them engaged in that is a great way to enter them with them. Amber, how'd they do?
Good.
Okay, great. Good job, guys. All right, Carolyn, you can't have a book, so sorry. Carolyn does have a question. Do you expect mobility to play a large role in how you practice medicine or how your providers practice medicine? So being a mobile provider?
By being a mobile provider, meaning you are bringing the record to the patient's visit.
I'll let Carolyn
The patient
expound.
encounter.
Yeah, so are you going to be using iPads and are you going to be using iPhones? Are you going to be taking your hardware with you to the hospital doing rounds?
Yeah, currently in my practice, we have tablets that we use, and I take my tablets into the room while I visit with the patients. When I started this clinic from the ground up, so it was we started with electronic record off the bat, and the patients knew that there would be the computer in the room with the patient. I elected tablets because I'm more mobile as to where I can look around rather than just staring at a laptop while my patient's over here. I do make it a point to sit down and engage the patient and make sure that I'm hearing what they're telling me. As a physician for 20 years, I found that you could actually be a very poor physician. But if you listen to the patient and if you hear what their concerns are and reflect that back to them and they tell them that you hear what they're saying, you're a great physician, even though you could be the poorest physician in all of South Dakota. I'm not the poorest physician in all of South Dakota, I don't think. But yeah, I'm very mobile with it. And in the hospital setting now, you know, as we go to hospitalists more and more, my role as primary care is getting less away from that, but I still do hospital work. I do go into the patient's room and I log onto the computer and check their vitals and their labs, and I can actually show the patient the labs and kind of trends and stuff like that. So yeah, I'm very mobile with my patient encounters.
I agree. I don't have a whole lot more to add. For the majority of our practices, we have tablets where providers go in and out of the rooms with. There's definitely a greater interest in iPads, especially on rounding and even iPhones. You know, our vendors starting to put out some more mobile type pieces that you can use on smaller things like a rounding list, or where I can view labs, maybe not document and order, and more things on the iPad. And I agree with Dr. Johnson in that I'm not a doctor, I'm a pharmacist, but I'm in the room sometimes we're rolling this out. And the most successful physicians in this whole journey are the ones that they use the mobile device as a tool, almost like a stethoscope, if you will. Because the challenge is you're sucked into working away from the patient and talking and communicating with the computer. You know, we see our providers really turn it around and have the patient sit next to them as they're ordering. You know, I'm gonna order you moxicillin as I'm writing the prescription. You're gonna take it 3 times a day. You're gonna take it with or without food. And while they're writing the script, they're engaging them in the EMRs and they're experiencing it with them, so they don't distract the patient. Their attention from the patients, and I think that's where mobile devices can help.
Have you had to change your physical layout of your exam rooms and things because of that, or just?
We have.
Okay.
I'm going to answer it in a little bit different way. We have a lot of satellite clinics where, especially our specialists go out to other communities and see patients. And of course, we want that documentation in our clinical record back at the home base. So what we discovered is that you end up recreating an awful lot of the infrastructure at each of those locations, or you give permission to tap into the clinic's internet connection. So we hadn't really anticipated that there would be that kind of complication for one of our doctors to go to Spearfish and see patients. But it certainly does add cost and complexity.
Yeah, I would agree. We kind of run into the issues with outreach providers as well, even meeting some of the meaningful use requirements. So after visit summary, for example, come stage 2, it has to be within 1 business day. Well, we've got outreach providers who go there, work, they don't have access there, come back, somebody prints those ABSs, mails them out, so they get credit. Now, if that isn't your primary, what they're primarily doing, you're fine. But it has to be at least, if it's over 50%, you run into not meeting the stage 2 requirement.
Well, and we have another question from Steve Larson. So, book. Steve will go ahead and get to check or pick one of the books. There's 2 books left.
3 books.
3 books. Oh, wow. 3 books left. Well, after Steve, there'll only be 2, right? Okay.
My math is right.
Steve's question is, our staff and providers are complaining that the nursing staff are spending all of their time with the computer instead of the patient. How should I address their concerns about patient care taking a back burner to the documentation requirements of the EHR?
Sure, I think reiterating patient care is always number 1. Now, keeping that at the top, how can we meet all of these requirements? Signing up for the patient portal or whatever it might be. I think it's really digging into those workflows and working together, communicating and gathering input and saying, okay, what isn't working, what is working. I've also found if you talk between certain nurses or even departments, you might kind of say, okay, this is working here, let's borrow and see if it'll work here.
I would just say that there are ways to have the nurse work with the EMR and still pay attention and give the patient their attention to the satisfaction of the patient. It's really just a workflow issue and how the nurse handles the questions. Which way is she facing when she's entering the data? Is she turning her back or not? It is a distraction having the physician or the nurse typing on that computer while the patient's in the room. Is a distraction from the patient, but you can really get around that by just paying attention to making sure that you're still hitting some of the strong points in terms of that personal interaction.
At the beginning, we're still, for the most part, really in implementation and adoption, regardless of what stage of meaningful use we're in. So that's a challenge. I always try to explain to people that technology has limitations, capabilities and limitations. The truth of the matter is all technology has limitations. So you've got to really understand that and work to really leverage the power of the EMR and maximize its capability by engineering good, solid clinical processes. Too often I see this question come up when we're expecting the EMR to think like we do today. We want the EMR to wrap around our existing paper process. We got to cut through that and know that this is kind of the new. And I say we're still building, the foundation with building blocks of data. As the record becomes a little more robust and we are a little more efficient, I think we'll capture that back. We're just in a growing phase.
Well, in a clinic setting, the nurses are involved with the patient care directly as they take the patient in the room and room them. They're going through their med lists and any doctors they may have seen in the interim, new prescriptions they've been put on. They are interacting with the patient. In a hospital setting, I think the definition of what a nurse is the question. What does a nurse do today? Back in 1950, certainly what a nurse did then is different than they do today. And part of a nurse's responsibility is patient safety. That's the whole process. I mean, isn't that, what was the name of that study? Several years back.
The quality chasm and the
patient safety issues. There's 100,000 patients die a year from errors that could have been prevented. That's the nurse's job. And the computer is what's really doing that. As they order medications, looking for drug interactions, communicating with the pharmacy about drugs that they're going to be giving the patient, ordering of procedures and that. So the nurse's job, I think, definition has changed. And so a physician says that to me, okay, prove it to me. I mean, you're just saying something that doesn't mean anything. Just because you say it doesn't make it true, in my mind. So I think that the whole point of electronic records, the whole point of the nurse's job is patient protection. And that's what's going on. That's what's happening. Plus you have medical aids who are really providing the comfort care there.
So I think I heard from all the panel that the workflows are very important, and I'm curious, and I'll ask the question of our audience, has the workflow assessment and redesign been part of your project before you implemented or after? So befores, hands up. One person. Afters. Okay. And the recommendation would probably be before, to understand how things are actually working, and where EHRs and technology can be inserted and efficiencies made. Would you agree? So that might help. Where are you in terms of implementation and adoption?
We have tested for stage 1.
Okay. Okay. Absolutely. So is workflow assessment redesign a one and done? I love Haley. No. So it's a continual process, and especially if there are 3 stages, 4 stages of meaningful use, and different types of products that we're using, that's a continual process. Okay. So my next question. And nationally, this is a question that is coming down the pipe, and people are concerned about this. And as a regional extension center, we are getting questions about who's actually going to get through stage 3. So my question to all of you, are you planning all 3 stages?
Yes, we are.
Okay.
Otherwise, I don't have a job. You want me to talk a little bit about maybe how we're planning?
Yeah, and kind of what that looks like, and at a large scale, and even at a granular practice level scale as well.
We as an organization set on this journey of EMR and HIT well before meaningful use. Meaningful use really just kind of gave us the endorsement that we needed to say that we're doing the right thing with a little incentive money, and by the way, they defined the timeline. So, we don't bank on delays. We plan, we move forward expecting it to be what it is. I'm looking ahead at stage 3, some language around stage 3 today, and it's just exactly what you think it is. The thresholds go up slightly, a little more emphasis on patient engagement, goes beyond patient engagement, almost to patient empowerment, self-management tools, beyond just access to data. Much more on health information exchange. In the end, what we're trying to do as an organization, and especially with my staff, the clinical IT staff, I really try to encourage them to look at meaningful use as the floor, not the ceiling, through all stages of meaningful use. So when we went live with CPOE, again, because it comes back to workflow and efficiency, meaningful use can't be a project you do off the side of your desk while you're taking care of patients. It has to be integrated into workflow to be successful. Because the point is we're supposed to be using it to deliver better quality care and at some point hopefully control costs. So it's not just about entering one med on 30% of patients who have a med. When we rolled out CPOE, we kind of made a campaign of universal adoption day 1. All orders, not just one med order on one patient. And so out of stage 1, I think our ED was between 90 and 100% of all orders placed electronically. On the inpatient side, we were between 80 and 90. That's kind of how we're approaching it. I'm kind of trying to to share with our organization that, you know, those organizations that moved through this time ahead, looking for opportunities to leverage the capabilities of the technology to do things beyond meaningful use, not waiting for the government to tell you when it's time to ratchet up the threshold, that you're going to be more successful. And it's essentially, because what this is a foretaste of the feast to come. When you start looking at the Affordable Care Act, you know, the discussion on the Affordable Care Act, in my mind, gets a little diluted with the insurance exchanges, the subsidies, the mandates. What gets lost in there is what, frankly, everybody agrees with. The World Health Organization has us 38 out of 191 countries in terms of our ability to deliver quality health care. But we shatter the curve as a percentage of our GDP. We know that's a problem. We have bipartisan agreement on that, and there are certain things within the Affordable Care Act that are positioning us for certain payment reforms. You know, shared savings plans under an ACO, readmission rates, value-based purchasing, bundled payments. All of these things are either tied to cost containment or quality or both. And the key here is, the reason we're doing what we're doing today is that, you guys familiar with the HIMSS analytical adoption pyramid? Kind of similar to meaningful use, came out before meaningful use. It's building of foundations, some clinical processes, but at the very top is business and clinical analytics. Once we get past this and we have this implemented and we're using it across the board, not paper process and electronic process, the key is we want to squeeze variation out of our process, use our data from the EMR on the back end to look for improvement opportunities, then to hardwire back into the EMR. And that's when we're getting our ROI on this. So we don't look at it as meaningful use. We're looking at what's after meaningful use.
So it wasn't really hard to tie to your mission and your values and everything, meaningful use, because I would assume quality, cost containment, those inpatient care is part of your mission as well.
Yeah,
So,
yeah.
great.
It's also positioned us to do some things with other payers too, not just CMS. So.
Great.
Tara, am I going to be going to?
Yes.
Okay. Yes, I will be planning on going all the way.
We love Dr. Johnson.
You know, I think we used to view meaningful use as a government incentive program, sort of optional, if you will. And I think many thought that it was kind of going to go away. And we now realize that, you know what, that was the tip of the iceberg. This is now part of our strategic plan moving forward. And it doesn't become about incentive dollars anymore. Now we have to add penalties to the mix. So now as we approach kind of that penalty phase of meaningful use, I think it's a given. We need to achieve meaningful use, and we need to be at the forefront so that we're working on those challenges and barriers. We're trying to forecast what those might be so that we can achieve it successfully.
One of the things that has helped us with meaningful use is in our clinic, and I know it's not this way in all clinics, but our physicians actually get the meaningful use incentive payment dollar for dollar right directly to them. That's been a great way to keep them motivated. We're far enough into the chain now where the $4,000 payment you get in the very last year, which isn't, I think that's 2 years away for us, but so you're kind of losing that part of the incentive, and hopefully we've instilled in the physicians enough of an idea of how to use the EMR to really truly affect their patient's health that they'll want to continue, even though maybe it's not called meaningful use anymore. And yes, there's penalties if you're not doing it at some point, so you can use that as an incentive. But we're really at a crossroads, at least at our clinic, where the money's kind of shrinking, and now we've got to find ways to keep the docs motivated just on what's really truly important, that's taking better care of the patient.
And I think physicians, and you can correct me if I'm wrong, I think that really is at the heart of what they do. They really essentially want to help patients, and I think their value system may easily be tied to meaningful use and just giving them the understanding of what it actually is. So thank you. So how are you communicating to your providers about your progress in your locations in meaningful use? Because I know a lot of patients have no idea what meaningful use is. They only see, oh, now there's an iPad in the room or a tablet, something like this. So how are you communicating your progress?
And that's with patients? Or the providers, patients?
Oh, no. How are you communicating to providers about your progress? Sorry about that.
That's a tough one. I don't know that we have anything necessarily formally, but you know, at a system level and even at a leadership level in our pockets of larger hospitals and whatnot, we had some good success with stage 1. I think Dr. Jacobs had mentioned it earlier today. We had, I think, 223 providers that were technically eligible, meaning they had the platform that they needed. 5 of them we didn't think they were quite ready, so we didn't sign them up to do it. But the remaining 208, or maybe there were 10. Regardless, we're 95% compliant. We had over 200 providers meeting meaningful use, despite the fact that everybody said we couldn't do it. And all 21 out of the 21 hospitals that were ready to do it in stage 1 made it. We had 5 that we needed some contract leveling done with, meaning bring their EMR whole to certification level. So we had some implementation to do in the remaining 5. They've now successfully attested. So we like to throw those statistics out there, put them in the hands of leaders to use as they wish, but not a formal campaign.
I would just say that we kept the physicians fully informed on a monthly basis as to how they were performing for meaningful use. Followed up with where they were not using the EMR correctly, get it corrected. We tried to make it as easy as we could. We actually created a quality program coordinator who one of her responsibilities is to make sure that the docs meet the meaningful use requirements. And so she was very active in communicating and meeting and sharing data and reports with the physicians.
No, that's exactly what I was going to state. We really kept our providers engaged on a monthly basis as well. They see not only their meaningful use reports, but we actually send it out to all of our own sites. So all of our Sanford providers have our own one meaningful use report, which I think was initially a little bit of a scary thought because that increased transparency. Everybody kind of went, ah. But now we really use it as a tool. When we see this clinic is really being successful on this objective, whereas this provider is struggling, what can we do and how can we share information?
All right, we have 2 books left. I know you have questions. It's not an easy job. So just one question that you may have had while you were driving out here or since you've been sitting in the sessions. Anybody? Well, I would like to thank our panelists. Give them a round of applause. They were not coerced in any way to be part of the panel. We just like to recognize the people, the movers that were mentioned today, and also, it isn't just the providers that are movers. It really is everybody within the organization who is involved in this. And I don't know if you can even do this type of project without involving everyone. So I think it would be a great idea within your own organizations to take this mover type of recognition and have that within your own organization, because it really does help everyone else to say, you know what, you're celebrating the success. You've had providers they've been doing it for a year or more now. They're moving into a full year of attestation. That's a lot of work. It's a lot of work to track that. It's a lot of work to attest for those providers, to change the workflows. So really celebrating some successes now, and keep planning that within your whole project as well. So thank you.
Thank you.